Hi there. Okay, so I'm going to talk today about medical overdiagnosis, but I'm going to start just by telling you a story. So this is Valentina's story. Valentina's in her 40s now, but when she was 28, she was pregnant with her first child, and she discovered that her mother suffered with Huntington's disease. So for those who don't know, Huntington's disease is a progressive neurodegenerative disease, a very distressing condition to experience and very distressing to witness in your loved ones. It causes progressive cognitive, psychiatric, and physical decline over a number of years. People gradually go downhill until they reach a point where they can't swallow, they can't speak, they can't walk. It is a genetic condition. If your parent has it, you have a 50-50 chance of being affected. So as soon as Valentina learned of her mother's diagnosis, she went from being a perfectly healthy person to being somebody who had a 50% chance of developing this serious neurodegenerative condition, which is as of yet untreatable and incurable. Worse still, her unborn child went from being, a perfect baby to being a baby that had a 25% chance of developing a neurodegenerative condition. Now you can sort of imagine the impact that this had on Valentina. She was devastated. She did have the opportunity. Genetic testing for Huntington's has been available since the early 90s. She could have had an immediate genetic test to find out if she did have the affected gene. She decided against having that test, and that's a common decision for people at risk of Huntington's. She realized that if she tested positive, that her entire experience of early motherhood, her entire life would be overshadowed by this impending neurodegenerative disease. So she chose to live with the hope that she could be negative rather than being confirmed that she might be positive. So she did enjoy motherhood, and a couple of years later she had another child, and she continued to enjoy her life. But she would say that even at the happiest times, she always had this sort of specter of Huntington's disease bearing down on her. It did not help that over the years she began to notice that she was becoming symptomatic. She had seen her mother's gradual downhill decline, and she began to notice the difficulties that her mother had experienced in herself. Often the early signs of Huntington's are things like cognitive change or psychiatric symptoms. She noticed that her personality was changing. She was becoming easier to anger. She also noticed some balance problems. She was tripping over things. She was bumping into things. As the years passed, she noticed this getting gradually worse. For a long time, she resisted the temptation to test precisely because she wanted to believe that her children would be healthy going forward, and she wanted to be a happy mother for her children. She didn't want the worst confirmed. It took 20 years for her to decide to test. She got to a point where she was so symptomatic that she was struggling to function. And in 2020, during the pandemic, she decided to have the genetic test once and for all to put an end to her indecision. She described the experience to me of going for the result. It was during the pandemic, and she saw the doctor walking down the corridor towards her, and the doctor was wearing a COVID mask, and Valentina was desperately trying to read the doctor's expression to get a sense of the news that she was about to get, but she couldn't. She was called into the doctor's office, and when the doctor pulled down their face mask, they smiled, and Valentina knew that she was negative at that moment. Sorry, I always get really upset when I tell that bit, because I'm so happy for her. And basically she found out, yes, the test was negative. She didn't have Huntington's disease, and her children wouldn't get Huntington's disease either. Now, I've obviously told you this story for a particular reason, but I'm going to leave it at that point, and I'm going to come back to it a little bit later in the talk. And I'm going to get to more of the nitty-gritty of what I'm here to talk about, which is medical overdiagnosis. I want to start with what overdiagnosis is and what it isn't. So overdiagnosis does not mean a diagnosis is wrong. It means that a diagnosis may well be right, but it's not benefiting the patient, and it's potentially doing harm. Medical diagnoses have been gradually growing over several decades due to changes in attitude to how we approach diagnosis. They grow by a variety of methods. They grow because we gradually move the diagnostic criteria to include milder and milder forms of disease. So we're gradually adjusting the line between normal and abnormal so that we're drawing more people who would previously been considered healthy into the category of illness. And this is sometimes called diagnosis creep. We also find that we are diagnosing more and more people through scientific advances and through improved technology and through more intensive screening programs looking for illnesses at earlier and earlier stages. So let's just consider how that has affected certain diagnoses. In the case of diagnosis creep, we're adjusting diagnostic criteria to find people at earlier pre-symptomatic stages of illness. An adjustment in what was considered to be high blood pressure from 140/90 to 130/80. When that adjustment in the cutoff point for high blood pressure occurred, it meant that in the region of more than 50% of people in the UK adults in the UK, would be reclassified as hypertensive according to that reclassification. When the definition for pre-diabetes, so a state that isn't diabetes but is a high risk factor for diabetes, when the definition of how pre-diabetes was defined, redefined by a slight adjustment in what was considered to be a normal fasting glucose, it meant that were the new definitions or diagnostic criteria applied to the entire Chinese adult population, 50% would be pre-diabetic. If they were applied in the UK to all adults, a third of adults would be pre-diabetic. We've seen the same patterns in mental health disorders and in neurodivergent disorders, a gradual change in what it means to have these disorders, the age at onset, the degree of difficulties that need to be there for you to get the diagnosis, has seen an increase in the number of people with autism of about 2,500% in the last several decades. We've also seen dramatic increases in novel diagnosis and early diagnosis courtesy of technology. So obviously now we can do whole genome sequencing in less than 24 hours. Genetic testing used to be done focused on individuals who had specific diseases that we wanted to explain. But now we can do genetic testing in a more speculative way, which means that we can find novel variants that we have never encountered before. And we can also use genetics as a screening tool to look for risks of, or to look for anticipated diagnosis in newborns, for example. So genetic screening is now being used on a trial basis as a newborn screening program to anticipate up to 250 conditions that are potentially treatable. Genetic screening is now used in healthy individuals to pick up cancer genes in populations that are thought to be higher risk of cancer than other people. We have technology that will allow us to detect asymptomatic cancers at an earlier stage than ever before. Technology, both imaging technology and liquid biopsies, will now allow us to, and the easier a diagnostic test is, the easier it is to roll out, which means that we now have opportunities to diagnose pre-symptomatic cancers more easily and at earlier stages than before. We're developing tests that will tell us that somebody potentially is going to, or is likely to develop dementia 10 years before the first symptoms emerge. So this is the way that diagnosis is, these are the ways in which diagnoses are expanding, so that we are diagnosing people earlier and milder, in milder cases. This is all done, I think sometimes when I speak to the general public, they often feel that this is all done, somebody's desperately trying to make a lot of money. I'm sure people are making a lot of money, but I don't actually believe that that's the driving force for how, for finding all of these diagnoses. I think the driving force really are good intentions. I think that much of the driving force is assumptions. So we assume if we find diseases at an earlier stage that we can promote long-term health. We assume the treatment that helps somebody who has a severe form of a disorder will be at least as helpful, or perhaps even more helpful, to people who have the more milder version of a disorder. We presume that people want to know their health future, even if it can't be changed. We think it's empowering to tell somebody that they have the risk of dementia in 10 years ahead of time, because of how that will allow them to plan for the future. And we also understand that if we're ever going to learn how to successfully treat diseases like Alzheimer's, we need to be able to recognize early sufferers to make them subjects of our treatment so that we can see whether treatments work. So I think that basically all of these kind of ways that diagnoses are expanding are driven by good intentions. But I'm obviously here talking about overdiagnosis, so I have a concern that these assumptions are not leading to the results that we would like them to lead to. So let's go back to the definition of what is overdiagnosis. So overdiagnosis is when the diagnosis may well be correct, but it's not necessarily benefiting the patient and is potentially doing harm. So we have multiple different cancer screening programs now, and why do I list that as part of the diagnosis? Well, we are assuming that every early cancer that we catch will progress to a stage that will become malignant and life-threatening cancer. What we're finding out from the follow-up studies of people being diagnosed with early cancer and screening programs is it simply doesn't work that way. There was a very interesting study published in the New England Journal in 2017, which compared high-income countries and low-income countries' cancer rates and cancer mortality. What they found was that the rates of cancer diagnosis in high-income countries was much higher than in low-income countries. One might expect that because they have better screening programs, they have better technology, people are more likely to be presenting for tests. But the mortality rates for cancer were similar in both high-income and low-income countries. What this is telling us is that a large number of those cancers diagnosed in high-income countries never needed to be diagnosed. There was also a recent study looking at all-cause mortality, following screening programs to all-cause mortality. And with the exception of colon cancer, in which all-cause mortality was prolonged by 11 weeks, in most cancer screening programs, there was no impact on all-cause mortality. What this means is that it may be that you can save some lives from cancer through intensive early screening programs, that you are probably having a detrimental effect on other lives through the treatment, through the unnecessary treatment that you're giving. If we think about the genetics advances, it's now possible to detect genetic variants that are completely unprecedented. And obviously this holds out a great hope for the future. But as things stand, we're diagnosing people with disorders that we don't understand, that we don't know where they're leading. They don't have any of the traditional benefits of a diagnosis. They don't tell you what the prognosis is. They don't lead to a treatment. They don't identify other sufferers. It is presented as empowering, but is it really empowering to be diagnosed with something that doesn't come with any of the traditional benefits of diagnosis? When we have intensive screening programs for things like hypertension, for example, we do it out of the good intention of thinking we can prevent strokes, and we can prevent strokes if we treat borderline high blood pressure. But you have to treat 100 to a couple of hundred people to prevent one stroke if you detect borderline hypertension at a rate of 130/80, which means to save every life, you're going to treat 100 or a couple of hundred people or subject them to monitoring that they didn't necessarily need. I think that really this was the point in me discussing Valentina's story at the start. A diagnosis is not inert. I sometimes think we look at this kind of improved rates of diagnosis and we measure it in the number of people lives saved from strokes or the number of lives saved from cancer. But what happens to all those other people who are subjected to medical monitoring that they didn't necessarily need? The minute you turn a healthy person into a patient through screening, you affect their relationship with their body, you affect their self-belief going forward. What happened to Valentina when she developed the conviction that she had the Huntington's gene is that she began paying excessive amounts of attention to her body. all of our bodies are a mess of white noise. You know, Valentina knew what Huntington's disease looked like. She began to notice things that any one of us would experience, like feeling flustered for a moment, tripping over things. These are things that happen to everybody. But because she had the expectation of Huntington's disease, because she knew what Huntington's disease looked like, when these things happened to her, she paid attention to them, and that magnified them. The more she magnified her symptoms, the more anxious attention she paid to them, and this had a looping effect, so that her symptoms deteriorated to the point that she felt disabled by them. This is the labeling effect, or the nocebo effect. When you label somebody with an illness, they can inadvertently, at an unconscious level, conform to that diagnosis. We're all familiar with the placebo effect. If you take a treatment and you believe it will be beneficial to you, it may alleviate your symptoms. Similarly, the nocebo effect will have the reverse effect. If you believe you have a disease and you are unconsciously on the lookout for the symptoms of that disease, you may develop symptoms accordingly. So I guess what I am here to say really is that medicine remains a clinical art, that we need to, first of all, put more thought into the harms that we visit on people when we turn a healthy person into a patient. We need to be more forthcoming with the general public about the pros and cons of this kind of search for early and mild diagnosis. It often benefits science, but not necessarily the individual who's being subjected to the early diagnosis. We must always put medicine in a clinical context and use technology going forward as something to free up the doctor's time to spend time with their patient, rather than considering it as something that can potentially replace the doctor. I'm a neurologist. You would never give a neurologist 100 scans and a scanty history to go with each one of them and say, well, what do you think is wrong with this patient? Scans don't diagnose patients. Technology does not diagnose patients. You know, medical professionals diagnose patients. I think we need to have more responsibility going forward for how we apply the technology that we have. And I think we need to continue to prioritize medical professionals in the role of looking after patients, because the most satisfying consultations for patients and the most reliable diagnoses come with a quality consultation between patient and doctor, where there is time. Perhaps technology will give us that time, but it certainly shouldn't replace us. Thank you.
Very, very interesting perspective. I guess this analogy, not only this analogy, situation also applies to people tracking their health now with health trackers, their phones, etc., and having all their, people who are not versed in medical science having access to their heartbeats and all that.
Listen, there's nothing worse for your sleep than something that tells you how you slept. You know how the best judge of how you slept is how you feel the next day. There's an awful lot of, paying excess amount of attention to your body is extremely unhealthy. Our bodies are not within our conscious awareness. Most of the time, our bodies are changing all the time. Every time you go up the stairs, your heart rate increases and your breathing rate increases. Every time you eat something, there's kind of stomach sensation available to be felt. But the minute we use devices to bring into our conscious awareness things that really shouldn't be within our conscious awareness, then we have the potential to mistake the ordinary thing for a symptom. And once you mistake something for a symptom, then you begin down the very dangerous road of medicalization.
Some of the diseases you mentioned, for instance, autism, ADHD, there's also Lyme disease, which you mentioned in the book, which is a seemingly very arbitrary list of symptoms that keeps growing and growing. Is there any scientific method applied to the way these diagnostics are being made and the criteria added to the list of what constitutes disease?
Well, I think, so I've talked a lot about Lyme disease in this book, because basically I want the general public to understand that medicine is a clinical art. I think there is a sort of a perception that you can go to the doctor and the good doctor will do a blood test and the blood test will tell you what's wrong with you. But actually, I would argue that the good doctor will say you probably don't need that blood test because tests are as subjective sometimes as the clinical examination, and I would rely on the doctor for the diagnosis more than I would the test. The difficulty with problems like Lyme disease and long COVID is that they have sets of symptoms that apply to everybody. So they manifest as brain fog. Well, who hasn't had that? You know, they manifest as tiredness. Well, we're all tired. And the difficulty with that is that these are available diagnoses to be used and abused, not by the patient, but by people who want to profit from patients, and that certainly happens in Lyme disease. Lyme disease is a diagnosis that can be given to almost everybody because it has almost every possible symptom. And it's fascinating because the misdiagnosis rate of Lyme disease is 85%, which is astonishing, but that's because it comes with a lot of vague symptoms. Long COVID has proven to be a very valuable thing to help people express distress during the pandemic, but it would be very hard to say that it was a singular disease.
Just a last question on cancer, because we'd always been told that with some particular types of cancers, once you feel symptoms, then it's probably too late to do anything about it.
Yeah.
And in the book itself, you mentioned that you do go to screening programs. You do that. So where do you draw the line there in terms of cancer screening?
Well, you know, for a personal point of view, you know, I don't want to put off anyone having cancer screening, but what I want people to understand is that there is a distinct difference between a symptomatic cancer and a cancer found on screening. A symptomatic cancer is a cancer that has already grown and is already causing problems and already needs treatment. A cancer found in screening, quite a large percentage of cancers found on screening will either progress slowly, that they will never cause health problems, or will not progress at all. And that means that if a cancer is found on screening, people have time to think. And that's what I want people to know, because the minute you hear the word cancer, you just think, well, that's it, I've got to go for the most aggressive cancer treatment available. And I think, you know, the better way forward is that people be aware that there are different types of cancer and that you can enter watchful waiting programs. If you screen 2,000 women for breast cancer, you'll save one life and you'll treat 10 women who didn't need to be treated. Those 10 women could perhaps have benefited better from a watchful waiting program that would have told them that they didn't necessarily need that aggressive treatment. Going forward with screening, I think it would be much more useful if we identified high-risk populations to screen. At the moment, we screen everyone, and the kind of people that come forward for screening are very often white, educated, middle-class people who are already motivated to look after their own health and are already living very healthily, whereas people from deprived communities, for example, are less likely to come forward for screening, and probably people at highest risk. We would probably get better economics out of these screening, you know, more lives saved and less people overtreated if we could focus our screening on high-risk communities.
Thank you. A very interesting point. Thank you so much, Suzanne.
Thank you.
Your book is out today.
Yes, it is.
The Age of Diagnosis.
Yeah.
The Age of Diagnosis is out today. It's on our bookseller outside. You've signed some copies?
Yes, I've signed some copies.
Thank you so much.
Thank you.
Okay.